before we get started, the subject today is urinary incontinence, but I thought I might just give you a little background. I've been in practice in Mobile now for 40 years. I did regular obstetrics and gynecology for probably 25 years. And then I narrowed my practice down to doing nothing but urogynecology. So I'm sure some of you may be asking, what in the heck is that? And basically, it is the treatment of female pelvic floor disorders. By and large, that falls into the category of incontinence and prolapse. And prolapse is probably known more commonly as your bladder's dropped. But basically, it's where any of the pelvic organs is lost support and finds its way through the weakest point, which is the vagina. So women who have prolapse will typically start feeling pressure and a bulge and then eventually external protrusion. Other things that I do are related to pelvic pain and urinary tract infections, pelvic floor muscle pain and discomfort with intercourse. We have a treatment for discomfort with intercourse that uses a laser technology for women who cannot use estrogen replacement, and it is very, very effective. So that's basically what I do. I have been full-time affiliated with South Alabama now for about 3 years, and I've thoroughly enjoyed it. It's been a wonderful facility. My office is in Estrada Clinic, and I do my surgery over at Children's and Women's Hospital. So let's just get right into urinary incontinence. We're going to talk a little bit about what causes it and how we diagnose it and how we treat it. So first, before we get started, I want to touch on some of the misinformation that's out there about incontinence. You know, a lot of people think that as they age, that it is just an inevitable part of aging in the female population, and that's certainly not true. Probably 50% of women will suffer from some degree of incontinence in their lifetime. Another myth, we often hear, you know, that, well, maybe it's not incurable, but the cures fail. So that's pretty much the same thing in my book. But that probably was much more true a number of years ago than it is now. We've benefited, as have so many things in our life, from progress, and we do a pretty good job of curing. We normally cite a cure rate of about 85%. That does not mean by any means that 15% fail. Most of the ones who aren't totally cured are certainly significantly improved. And then a lot of people who have never experienced just think it's kind of a non-issue, but that is far from the truth. 10% of those who have it, it's severe to the point where it is the reason for a lot of elderly women being admitted to nursing homes so that they can be cared for. So what are the different types? Well, we're going to highlight today stress incontinence and urgency incontinence and mixed incontinence, mixed being a combination of both stress and urge. Urgency is also known as overactive bladder. And then under the heading of other, there are some very unusual causes for incontinence that we're not gonna get into today. So let's talk a little bit about stress incontinence. In order to diagnose it, we take a good history, and basically the history for stress incontinence is a leakage of urine that accompanies a sudden increase in abdominal pressure. most commonly a cough or a sneeze, but as it gets worse, maybe just lifting a heavy object. But anything that causes an increase in abdominal pressure is accompanied by a leak. In physical exam, it may be perfectly normal as far as the vaginal exam, but usually, most commonly, we can see that there is a lack of good support under the urethra and under the bladder neck. And a lot of times there may be prolapse, vaginal prolapse, accompanying the incontinence, but that's not a necessary component by any means. Sometimes a bladder diary can be useful. Typically, in a normal female, you would void maybe 3 to 5 times a day and get up as often as twice a night. Some of you probably go far in excess of that, but that's kind of what we look at as normal. Uroflowmetry is simply a little device we have in the office where you empty your bladder, and there's a little machine that catches the urine, and it measures the volume and the rate of flow and the pattern of flow. What we look for is just a normal bell-shaped curve for a normal flow pattern. And then we want to always make sure that the bladder is emptying properly. So we check after the bladder is emptied, we check to see how much is left. Nobody empties their bladder completely, and anything less than about 3 ounces is permissible, meaning we don't really worry about that. Most of you would have a volume of maybe 1 ounce or less. And then we want to always make sure that there's not a bladder infection, because bladder infections can and frequently do cause urinary incontinence. So let's talk a little bit about the treatments. Initially, in mild cases, pelvic floor muscle exercises, or what are known as Kegel exercises, can be very helpful. They rarely will cure incontinence, but they may keep it at a level that's very minimal and manageable without any further treatment. Weight loss. Interestingly, a weight gain, a significant weight gain, will frequently precipitate incontinence. And so the converse is equally true. If somebody has, and this is especially true in mild incontinence, but if somebody were to lose, say, 50 pounds, it might correct the incontinence. A pessary is simply a device that's inserted in the vagina and occupies space, and it puts pressure on the bladder neck, and sometimes that can be helpful, especially in situations where surgery needs to be delayed. It's probably not a very acceptable option as far as a long-term option. And then there's surgery. And we're going to go into more talk about what we offer in surgical correction of stress urinary incontinence. So a long time ago, and I'm saying maybe 30 years ago or longer, bladder tack, or anterior colporphy, we call it, was used to correct stress incontinence. It had a high failure rate. The success rate was 60%, but that was a short-term success rate. And generally, over time, that success rate declined. This terminology is an operation that was very successful. It was done through an abdominal incision, and was pretty involved a hospital stay, and a fairly significant recovery period. But like I say, it was very successful. The needle procedures were not very successful and quickly fell by the wayside. This operation, again, is another successful one, but is very involved and involves abdominal incisions and a pretty significant recovery period. So that leads us to the operation that we do on a very regular basis. It's called a mid-urethral sling. We usually refer to it simply as a sling procedure. And it's an operation that's done vaginally. It does not involve any abdominal incisions. It has a higher success rate than all of its predecessors. And this is a picture depicting what it looks like. You can see in this in these drawings, the one on the left shows a sling resting under the urethra and coming out through two little puncture sites in the abdominal wall right above the pubic bone. The one on the right, again, same place under the urethra, but is routed out laterally so that it comes out through two little puncture sites in the skin at the leg crease. These were the initial sling procedures that we did for years. And most recently, the procedure I've been doing starts, again, rests under the urethra at the same exact place, but it does not have any exit sites. It just embeds into some fascial layer within the body so that there are no exit sites. So basically, what we have is a sling procedure that's designed to support the urethra so that then with a cough or sneeze, instead of that mid-urethral tissue descending because it doesn't have good support, it has a little backdrop. So then it descends, hits that, and that keeps it from leaking. It's a procedure that is short. Normally it takes 20 to 30 minutes. It's outpatient. And this is all in contrast to the operations that it has replaced. It's done with local anesthesia and sedation. Some doctors put patients to sleep. I would say most do, but we found it very satisfactory to do with just sedation and local anesthesia, and it is done without any discomfort at all. The advantage of not general anesthesia, obviously, is wake up quick and you're discharged quickly. It has a low complication rate, probably 4% at 24 months, which is very low compared to any operation. The outcomes are comparable or superior to the procedures that I mentioned earlier. And it has excellent durability, meaning that you can count on it to last for a lifetime. There are studies that are still ongoing that have followed women after this procedure for the most recent information I have are women that are 17 years out, and there's been no diminishing in effectiveness. And if there are complications, they're minor and easy to fix. So this is in contrast to a lot of what you hear about any kind of procedure that involves mesh, because this sling is made out of mesh, but very important, it is an operation that has never come under question by the FDA or any of the other organizations who've looked into this. In fact, it's considered the gold standard of surgery for urinary incontinence. And just to elaborate on that for just a second, all of the fanfare about mesh complications and the lawsuits and all of that involved operations that were done to correct prolapse, not urinary incontinence. So that's kind of a real quick look at stress incontinence. We're going to look at urge incontinence now, also referred to as overactive bladder. That affects a large percent of women and is age related, unlike stress incontinence. Overactive bladder or urgency incontinence typically gets worse with age. It's defined as urgency to urinate, usually accompanied by frequency and nocturia, meaning getting up frequently at night, and with or without incontinence in the absence of a urinary tract infection. Now that's the definition of overactive bladder. The urge incontinence is overactive bladder with the incontinence. On physical exam, there may be normal pelvic organ support, good support of the urethra, no findings of significance. And we, again, want to be sure that there's not a bladder infection, because bladder infections cause urgency and frequently are associated with urge incontinence. Bladder diary may be helpful because typically we'll see a record where women void frequently during the day and often frequently at night. And we can get an idea of how many times they actually have accidents from that as well. So this is a little cartoon that shows overactive bladder. On the left, you see a bladder that is relaxed. You can see that it is half full, and normally in normal bladder function, that bladder muscle stays relaxed until you tell it to contract. With overactive bladder, the picture on the right, that bladder is only partially full, but unbeknownst to the woman, it just starts contracting. So typically there'll be a threshold of filling, and once it reaches that threshold, it's like pulling a trigger, and you can't do anything about it. In its worst forms, it is far more debilitating than stress incontinence because it's unpredictable, and frequently the bladder will empty in its entirety. So it becomes very debilitating and restricts activity of any sort. So what are the treatments that we have for overactive bladder? We divide them into 3 levels. Level 1 is non-procedural, it's behavior modification. Bladder training refers to a technique where we teach patients to, when they get that urge, the thing you automatically want to do is run to the bathroom. And that's probably the worst thing you can do. If you can just pause and try to let that sense of urgency pass, normally it will. And then you can get back, you'll be back on top of it, and then you can get to the bathroom on your schedule and not on its. So that's a very good technique to learn. Pelvic floor muscle therapy is treatments to help you learn how to relax those pelvic floor muscles. Scheduled voiding is something that is extremely helpful in women who don't have that much frequency. Say maybe they're voiding 4 or 5 times a day, but they may have a couple of hours between voids. And with scheduled voiding, what we teach them to do is to go on a time schedule. The idea again being that you want to interrupt the filling phase before it reaches that threshold where it pulls the trigger. So you may find that you could go to the bathroom every 2 hours and be perfectly fine, but if you waited 2.5 hours, you're going to have an accident. And it's just a matter of finding that interval that works for you. Fluid management is the other side of that equation, because obviously if you drink too much fluids or drink a lot of fluids, you're going to go more frequently. Or if you drink caffeine products or things that make you urinate more frequently, you can expect to go. So it's a matter of learning what you can drink, how much you can drink, and coordinating that. A lot of people that I see have the misinformation, I'm going to call it, where they think to be healthy they've got to drink 64 ounces of fluid or something that's totally way beyond what's necessary. So it's important to realize that, and it's obvious. The more you drink, the more you're going to go. So you can to some degree help with overactive bladder by decreasing fluid intake. So then we get into level 2 things, and these are drugs that you can take and that often are very effective. The first drugs are in a family that pharmacologically we refer to as anticholinergics. These are the drugs like oxybutynin, Detrol, Vesicare. There's a whole host of them out there, and they can be very effective. The side effects are dry mouth, constipation. Sometimes they cause drowsiness. And the thing that we worry about, especially in older women, is that they can impair cognitive function and cause some dementia. And so we obviously have to be very alert to that. The next drug is Myrbetriq, which is the generic is Mirabrigon. You've probably seen television advertisements for this drug, and it does not have any dementia associated with it. It doesn't have the dry mouth or any of those other troubling side effects. It sometimes, not often, but sometimes will aggravate hypertension. So we have to be careful to monitor blood pressure in women who have high blood pressure. It can cause some pharyngitis or sore throat, itchy, scratchy throat, and headache. And the third drug therapy is estrogen replacement therapy. And by this, I'm not talking about the taking it by mouth or by injection or whatever. Most often in women who are not already on estrogens, we use a vaginal estrogen replacement. So this can be in the form of a cream, a suppository, and by restoring normal estrogen content to the vaginal tissue, it also has a favorable effect on the bladder tissue, and that frequently can be helpful. So then, if you have, if we see patients who've tried behavioral therapy, they've tried the drugs, and nothing seems to be helping or not helping sufficiently to favorably impact their quality of life, then we go to level 3. I don't know why I'm not getting to level 3. Here we go. Okay, sorry about that. So level 3 really falls into 2 primary categories. One is Botox injections into the bladder, and the second is neuromodulation or stimulating some of the drugs, some of the nerves to the bladder. We'll talk about Botox. As most of you know, you typically think of Botox in cosmetic procedures where it flattens out wrinkles. And the way it works is it paralyzes the muscle underlying the wrinkle. So when you paralyze the muscle, you can't wrinkle anymore. And it's used in multiple applications in medicine today. But this is a very unique application because what we do is we inject Botox into the bladder and into the bladder muscle with the idea of partially paralyzing that bladder muscle so it's not so irritable. And when we do that, we do it, it's an office procedure, we numb up the bladder by putting a solution in there that numbs it up, and then we inject different sites within the bladder muscle itself. And if you get a good result from that, it can be very dramatic, often giving at least 6 months of relief. If you get a good result and you've gotten 6 months of relief, most patients who have severe overactive bladder are happy to come back and do it again. It is a minimal amount of discomfort, and like I say, it can be very dramatic. The next thing is the neuromodulation, and that generally, we look at that in two applications. There's sacral nerve stimulation and there's posterior tibial nerve. With the sacral nerve stimulation, we put a little electrode through the low part of the back and find a nerve that goes to the bladder and stimulate that nerve. And if we get a good response, then you can put a permanent battery pack, embed that under the skin, kind of like a pacemaker would be up here. This would be under the skin of the buttocks. And by a constant stimulation of that nerve, it will reduce the urgency and frequency and urge incontinence. Posterior tibial nerve, on the other hand, is a little electrode we put in just above the ankle. And it's just a 30-minute procedure. We do it in the office. And what that does is it goes up to a nerve that goes to the bladder. So it's kind of what we call a reflex arc. It goes back up like it's headed to the brain, and then it jumps over to a branch going to the bladder. And we do that on a weekly basis, 30-minute treatments. And after a certain number of treatments, then we reduce it to just once a month. And again, that can be very dramatic. The benefit is that it's minimally invasive. I mean, it's a tiny little needle that you can't even feel being inserted. But the downside to it is it does require weekly treatments initially. So this is going back. This is just a cartoon that shows the Botox injection. You can see the doctor has a scope. He's looking into the bladder, and in this little area up here, it shows what he's seeing. There's a needle that's inserted through the scope, and it's just the tip of the needle that is injected into the bladder wall. So there are multiple injection sites to cover a large part of that bladder muscle. So I think that brings us to the end, and I am open to questions.
Dr. Haynes, we have a couple questions in the chat. I can read them to you, or you can pull that up yourself, whatever you prefer.
Oh, in chat?
Yes.
Where I'm not seeing chat.
It would be in your Zoom window. We're seeing your PowerPoint.
Oh, so cut off my PowerPoint?
Yes, sir. Oh, yours is different.
All right.
I'm happy to read them to you. It seems like yours is in a different window.
Yeah.
Okay. The first question is, does urethral erosion occur with the MUS, and what complications occur?
No, urethral erosion does not occur with the midurethral sling. The most common complications we have, well, there's several. If the sling is put in too tight, then it makes it difficult to urinate. So that's one of the reasons that I do my procedures under local and sedation, because what we do then is once it's in, then we fill up the bladder, have a patient cough, we can see it leak, and that way we can know exactly where to tension it. So it's enough to keep from leaking, but not too much. The other complications are that if it's put in too superficially, in other words, not deep enough under the vaginal tissue, then it can erode. You can get a mesh exposure, which typically will cause some discomfort, especially discomfort with intercourse. And in the first case, if it's too tight, it's easy to go in and loosen it. A simple, really literally about a 10-minute procedure. If there's an erosion like that, we'll go in and remove part that's too superficial. A lot of times after removing that, the incontinence does not come back because we leave some of that mesh in, and it continues to support the urethra to some degree, but it may recur, and if so, then we go back to treating that. I think those are the main things that we see. I've got a question that somebody sent in by email, and it said, discuss treatment for an older age woman, in this case 72, who has multiple sclerosis and has urgency due to what we call a neurogenic bladder. And that's an underlying muscular or neurological condition that's causing that. And that's a difficult problem. This patient said that she'd been on Myrbetriq and didn't say how much benefit, but apparently not much, and wanted to know specifically if the ankle implant, and by that I think she's referring to posterior tibial nerve stimulation, if that would be helpful. And I would say it's worth a try. We do have it, we are using it, and we've had good results, but I can't say I've treated anybody with multiple sclerosis or any other underlying serious neurological condition. So, but like I say, it's worth a try. So what else?
Another question is it possible to have both of the bladder conditions that you described?
Yeah, absolutely. And that's what early on in one of the initial slides I mentioned. We're going to discuss urgency incontinence, stress incontinence, and mixed incontinence. Mixed is the combination. And so the way we approach mixed incontinence is we try to sort out which of the two is the dominant complaint and treat that. If we treat that and we're getting benefit, but there's still the other side is still a problem, then we treat that. And so it's not uncommon for somebody to have, say, a midurethral sling for the correction of the stress component, and then still need to be on medications for the urgency component.
What are recommendations for those who have incontinence when sneezing?
We pretty well covered it. I'll just go back over it quickly. I mean, if like most of the times we can anticipate a sneeze, right? So it's a matter of trying to you can do like a Kegel exercise, like tense up the pelvic floor. If you can sit down, that would probably be helpful too, and just tense up real good and see if that will control it.
All right. Would you recommend staying on Myrbetriq long term or having surgery?
Well, that's a good question, because again, if we're talking about exclusively urge incontinence or overactive bladder, then we don't have surgery to offer for that. Well, I'll take it back. I mean, we could do Botox injections, but I wouldn't do that if the Myrbetriq is working fine. So there are no surgical go-tos for urgency incontinence. So if the Myrbetriq is working, you can stay on that long term You don't build a tolerance to it. And I'd say go with that. If you, for whatever reason, want to discontinue the Myrbetriq, then you could consider the Botox or one of the neuromodulation treatments.
All right. What percentage of stress UI is helped with pessaries?
It's helped.
Help.
Yeah, I don't have an answer to that. I would think that it would probably be between a third and a half that would be helped. Again, that is attractive for somebody who wants to avoid surgery or for whatever reason can't have surgery. As far as a long-term solution, most people don't like that idea, but that's not for me to decide. That would be certainly an appropriate thing to try.
All right. And looks like our last question is, do you do biofeedback strategies?
Well, the biofeedback, with physical therapy, it can be very helpful with urge incontinence in particular. It can be helpful for stress incontinence too. With the stress, it's like, again, teaching you how to do a Kegel exercise. And with the biofeedback, it takes the guesswork out of it because those muscles in the pelvic floor are hard to associate with. It's not like you can feel your biceps tighten up. It's, most people, when they tighten up their pelvic floor, they're tightening up everything. But to tighten up specifically those muscles that help support the urethra can be tricky. So with physical therapy, it helps identify those muscles and be able to strengthen them. There's a technique in physical therapy that we call electrical stimulation, and that also helps with building strength in those muscles, and can be helpful, again, with urgency, helping you learn how to tighten the muscle long enough for that sense of urgency to gradually subside, so then you can get to the bathroom on your schedule and not on your bladder's schedule.
All right, we did have one more question. How do you measure how much urine is left in the bladder after voiding?
There are two ways to do it. One is with an ultrasound. One is with a little catheter that we insert. It's literally about that big. I mean, it's real thin. We insert that we have a patient void, insert that, and measure the residual. And most of the times, I have to say, when we do that, a lot of times patients aren't even aware we've done it. So it's not like what you may have experienced or maybe envisioning with a big catheter and the discomfort associated with that. It's just an in and out catheterization just to empty the bladder.
All right, that's all of our questions. Thank you, Dr. Haynes.
Thank you.
Will be on Facebook and on YouTube, and will be in the water cooler for anyone that wants to see it again or share it or anything.
Great. Well, I hope everybody has a wonderful day. It looks like the weather's gotten better, so that's good.
Thank you.
All right.